This visionary. So, well, we'll start the discussion now on all 4 topics at the meantime. So we had 2 slides to, they're all green, to get started with the discussion.
So we have already gotten into this discussion, and I'm just going to go back 1 slide, I'm sorry. The first question that we're really asking is, do we need multi-gene expression tests? Whoops. Keeps going forward. Can we? There we go. Do we need multi-gene expression tests in node-negative, ER-positive, HER2-negative breast cancer? I think we've heard a very forceful statement from Christos saying we need in all, and we've heard a considerate statement from Fatima Cardoso. Fatima, this is your moment, that we need it in some, if not most. Fatima, would you just like to repeat the statement that you made? And can we have some input from the audience? How are you using gene expression tests in the node-negative luminal breast cancers right now?
I think Christos is right.
Fatima, go.
So my suggestion would be that, and what I fight with the reimbursement bodies is that within the luminal or luminal-like breast cancer, whatever you want to call it, there are situations where all our clinical pathological factors are indicators of low risk. In that situation, I don't think there is doubt, and we don't need to ask a genomic test. There is also some situations where all the factors point for a higher risk. And also there, you don't need. And there are still also those where you have some factors of high risk, some factors of low risk. And so let's say that you have 3 positive nodes, grade 1, it can be, and you are a bit confused with the Ki-67 that it's intermediate and you don't know exactly what to do. And we should reserve the genomic test for the cases where we are in doubt of what we should do. I know that in the ideal world, you could ask for all because there are small percentages of those that can still have a different genomic risk, but I don't think it compensates in terms of cost.
Thank you for the statement. So there's a low, there's a high, there's an intermediate subset of patients. Let's reserve it for that. That's the statement. Would someone from the panel like to comment on that?
Well, of course, I'm a statistician, so I have 2 examples, one supporting one side and one supporting the other side.
I was afraid of that, Richard.
In support of you do not need it for all patients is, and they both come from SOFT and TEXT, is the example of SOFT, where without genomic assays, investigators were perfectly able to detect the very low risk. So the patients enrolled in SOFT who were not offered chemotherapy did exceptionally well, irrespective of the randomized treatment, up around 97% disease-free long-term. This is without any genomic assays. At the same time, in TEXT, we had 2 strata, chemotherapy and no chemotherapy, and there was a 3rd trial, SOFT, TEXT, and PERK. PERK permitted investigators who were uncertain about chemotherapy to randomize chemotherapy yes and no before randomizing to the endocrine therapy. We enrolled 26 patients. At the same time, TAILOR-X was run, and because there was a number, 6,711 patients were randomized to chemotherapy or no chemotherapy. So again, investigators are very able to determine the lowest risk, and there's some comfort in having a number.
Kent Osborne, microphone 3.
Can I make a comment, Peter? Because I think, sorry,
There's 2 reasons, obviously, to consider a genomic test. One is prognosis, one is prediction. What if you have a patient who you know is high risk because they got a bunch of positive nodes, but some of these genomic tests tell you that they're not going to respond to chemotherapy anyway. And so I think that may be of value even in someone where you think it's a high-risk patient, but that doesn't necessarily coincide with benefit from chemotherapy. So I think I would consider that as a reason on the pro side, although I don't get genomic test on everybody.
Fabrice, you want to keep going with your statement before we move to the node positive subset?
I wanted to comment on something else than risk prediction that is, I think, important in countries where there is social medicine, is the question of equal access of care. So in France, if you are treated in a local small center, I mean, the pathologist has not the same expertise as if you go to Institut Curie or the best place. My personal perspective on genomic tests is that it allows everyone to have a central assay that will give the same access to good care to everyone. So I think beside the question of risk prediction, in countries where there is social medicine and where equal access to care is important, we have to think about central testing and giving the same chance to all the patients. And I think genomic tests are exactly doing this job.
So let me ask you this.
Can I comment? I don't have a micro. Maybe it's by purpose. So
sure.
Fatima. So this is the whole point. So when I'm saying that I'm in favor to do no patients, of course we're adults and we can decide whether you want to prescribe this assay or not. But because many of our patients are treated in local clinics, that we don't have Mr. Beppe, Mr. Salgado, and in next by, I think that if you want to be fair and don't, you know, and think this is a curative setting, so I think it's ready for all of the patients. And I have an example. I don't want to give examples because again it's still for personal opinions, etc. But clear, the data shows that in any single data set, we have 2 prospective clinical trials that the clinical pathological variables alone cannot be as good as with the genomic assay. So I don't still understand why we are 15 years later on from our US colleagues and we're discussing whether we should prescribe this assay or not. We are in a curative setting, and of course the absolute benefit in low clinical risk is small, but still there are patients that would benefit, and I think for me it's unethical today to not discuss that and not be able to have these assays in order to make the best decision. Think about that, and we have actually 2-3 days before Saturday morning to discuss about that.
Christos, thank you.
Eric?
Go ahead, Eric.
So I find myself in the funny position of agreeing with Fatima. And the reason for that is outside of a research setting, assuming you are in a place where you trust the pathology, and I acknowledge that there may be places where you need standardization, you don't have it, and the only way to get it is to get a genomic test. But just as any clinical variable doesn't stand by itself, a genomic test doesn't stand by itself. And so if in fact you have a patient with entirely favorable factors, grade 1, strongly ER/PR positive, not a tremendously high anatomic burden of disease, I don't really care what that genomic test shows because I'm not going to necessarily treat that patient with chemotherapy given the other factors. So I mean, I think that this whole idea, again, outside of a research setting and within the context of a center where you trust the pathology, I think the whole idea is you need an extra test if you or the patient are undecided about what to do in terms of chemotherapy.
Professor Viale, Milan.
Yeah, I would offer Fabrice 2 possible alternatives. The first one is, give me 100 euro, I will run pathology for you. and the second is that I think we have to invest in education of pathologists because, as has been discussed, I agree that this molecular test may offer something in addition, but in addition to what? To the best possible pathology. So I think we have to ensure the best possible pathology by educating, by investing in education, even for pathologists.
Thank you, Beppe.
Where is Eric? So actually, I can actually disagree with Eric Weiner. Okay, I'm dead. But you know, I mean, think about that the meta-analysis actually showed the same relative risk reduction in node-negative low-risk patients as well in node-positive disease. So if the genomic assays allows you to identify those thin clinical low based on grade and grade 2 tumors, and etc., and if you can actually enrich and identify those patients that actually may be cured, even if the numbers are so small, I think today is unethical not to prescribe this assay today with the clinical pathological variables. This is the data. I'm not me, I'm not my gut feelings, I'm not my personal opinions. This is based on the data. On thousands of patients based on meta-analysis, on 1,000 patients using and applying clinical pathological variables together with genomic assays.
Anyway, for recommendations, I think we should stick to the data. We have strong data. We have spent 20 years building them, so I think we should stick to the data, and the pragmatic view of the pragmatic use of test or whatever is something that has to be declined by institution, by country, whatever. But I think as a conference of consensus conference, we should stick to data.
Microphone 1, please.
Antonio Wolf, Hopkins. Rich, I just want to follow up on what you said about why TAILOR-X did well and why PERK did not. And I think it is essentially, like a lot of things that the IBCSG has done over the years, it is a study that was ahead of its time. Because it was essentially a chemotherapy de-escalation study. Endocrine therapy plus minus chemotherapy. A study was launched 15, 20 years ago when we all, quote unquote, knew that chemotherapy had to be given. And it was, if that study had been done today, it would accrue like gangbuster based on what we know. And essentially what you're saying is not that a genomic assay is needed, a number was needed for clinical practice. A number would have been needed in that setting simply as a research tool.
Shall we? Go ahead, you have one comment?
No, we have 2 minutes left, so we should pick the right question we want to ask now and get answer from the audience or discussion, because we just have 2 minutes left.
All right.
So what about the decreasing adjuvant endocrine therapy? Well, we don't have any tools that are relevant for that.
No, but I think we have the data not to predict, but at least we have now emerging body of evidence that 5 years of endocrine therapy is a real toxic treatment.
That's clear.
And because it's toxic treatment, we need to find a way to spare some patients this toxic treatment. So I don't know if it's feasible to predict which patients should avoid endocrine therapy, but it seems to me it's a need.
Maybe there's someone here from the Netherlands. They have more examples of patients not receiving endocrine therapy in large cohorts. They have some very impressive epidemiology data. Microphone number 4.
Yes, I'm Dr. Apfelstedt from Cape Town in South Africa, and I wanted to ask here, how relevant is a 2% improvement in the survival by chemotherapy in a low-risk genomic patient? Just an example, the majority of the breast cancer patients are going to be in the 50-plus age group, where the principal mortality in the 50 or 60-year-old age group is already 4%. Above age 60, it exceeds 10%. Furthermore, we must ask ourselves whether the converse figure of 98% of patients, 98 women out of 100 are exposed to the toxicity of chemotherapy without deriving any benefit from it. Is that justifiable? Certainly not in the context of my practice. Thank you.
I think we...
Can I reply to that question?
Sorry?
So, for the question about 2%, ask your patient if she agrees whether she's going to get chemotherapy. We're talking about cure. Now, for the 98% that maybe get chemotherapy for nothing, you should actually prescribe the genomic assays to identify those that do not need chemotherapy.
Okay, shall we just move to the node-positive setting before we go to the welcome reception? Just one more question, and I'll have quick statements from everyone. Are you using gene expression in node-positive? And I'll just want quick answers from all of us in the panel there. And I'll start with saying, yes, we are using it in node-positive.
Node-positive.
Fabrice, you want to? Oh, I have to. It's not positive disease.
It's been doubled.
Disease. So again, this is my personal opinion. This is based on the data. So not positive, we don't have the data. I think that chemotherapy, no, we have 1, 2, 3. And 1, 2, 3, we have MINDAC. When MINDAC says discordant cases, you know, MINDAC actually shows that you should give chemotherapy when you have discordant cases between, you know, clinical and genomic. This is what MINDAC actually says. Well, not significant. Okay, well, this is how I see the data. So not positivity, this is again mixing prognostic and predictive markers. I don't have the answer. So, you know, more having not positive disease, we have more advanced tumor burden, we have more micrometastases, but it doesn't mean necessarily that we benefit from chemotherapy. And I think, again, you know, chemotherapy works by killing proliferating cells. I think that we will see in a few years whether, you know, in not positive, those assays are helpful to identify those who really benefit from chemotherapy.
Okay, I think the last phrase was, we don't have the answer to this question at the moment, or at least not a definite answer. Please move on to the welcome reception. There's a wonderful dinner waiting for you outside. I would like to thank all speakers and my co-chair, not only for fantastic talks, but for your contributions to the field. Thank you.